Hello, coders. Good morning, good afternoon, good evening, all depending upon where you are joining us. So, how are you all doing, coders? Welcome to the Evaluation and Management Group Study Week 2 by AMCI. So, after successfully completing the week 1, we are moving to the week 2, and I have got a lot of new chapters to review and good scenarios as well with me. So, are you ready, coders? I know you all are. And before starting, let me introduce you all to my team, the fabulous team here. They are the pillars of Tuesday Study Group. Let me introduce Miss Tanya. We have Miss Karen. We have Miss Sandra and Miss Stephanie joining with us, and they are the ones who are encouraging you in the chat, motivating you to keep going. And let's welcome them. We have Ms. J with us, AMCI Curriculum Director, and that's me, Mr. Sandeep, your instructor for the group study, and I'm joining you all the way from UAE. So let's start. What are the key words to highlight for an E&M documentation? So it's a little bit different from what we highlight for the other coding scenarios. We highlight the age of the patient, the diagnosis, the signs and symptoms, the exams, the procedures, anything which the doctor does, the total time, the medical decision making data reviewed. How to select the E&M code? Answer or do the following thing. Would ask a few questions to ourselves before selecting the E&M code. Whether there's a medically appropriate history or exam performed, the location of the visit, whether it's an office visit, the type of the visit, whether it's a new or established visit, total time of the visit, and medical decision making. Finally, E&M tables to select the code and apply all the guidelines. So how to select an E&M code based on time? Answer or do the following. So in while selecting the E&M code on the basis of time, we will skip one step from what we saw in last previous slide. Answer or do the following: the history or exam. We will check the location of the visit. We will check for the type of the visit, whether it's a new or established. Total time. Then we will skip the point number 5, which is medical decision making. Yes, if time is documented, we will skip that particular step and we'll move on to the sixth step, which is E&M tables to select the code and then apply all the guideline. How to select the E&M code? Okay, this is when there is no time documentation. Steps are pretty bit similar. So we will check whether there's a medically appropriate history or exam, the location of the visit, the type of the visit, whether it's a new or established. So medical decision making. So there will be no time documentation in this scenario. So we will take the help of our PDR chart. We will do the inventory and then score. Yes, that's what we do. An E&M table to select the codes. Finally, apply all the guideline. Yes, review and score the documentation for the MDM. So since we know that MDMs are evaluated and scored based upon these three categories, I will be referring them to as three items such as PDR. So P stands for the number of problems and complexity of the presented problems. D stands for the amount of the data reviewed, and R stand for the overall risk. So just for your information, the PDR chart is available. Yes, where is it available? It's available in our MCG manual. So this is the latest PDR chart. We have added few codes for the hospital observation, the consultations, nursing home. You can see all of those codes in the final code column. So they have been updated and they are available in your MCG manual. So let me quickly look into the chat. I want to see how you all are doing. Okay, so we previously we reviewed the home visit, the medical team conference, the preventive medicine, medical care plan oversight, and solve some scenarios. So you all rocked that session, rocked that week. Now we are going to review, we are going to see how to score an MDM, neonatal intensive care services, care management, transitional care services, advanced care planning, standby services. These are the goals for today's class. And so let's start by doing a few scenarios on office visit review. And I know you all are ready. And this is the first scenario for you. And I would invite Miss Stephanie to read the first scenario. Miss Stephanie, thank you, and please.
Thank you, Mr. Sadiq. A hello, coders. What ENM code is reported? A 99212, B 99213, C 99214, and D 99203. A 45-year-old male with a past history of well controlled hypertension presents to the office for a routine follow up. The patient reports no recent health concerns. His hypertension is well managed with his current medication, lisinopril, 20 milligrams daily. He denies any symptoms of chest pain, shortness of breath, headaches, or dizziness. He has been checking his blood pressure regularly at home, and the readings have been within normal limits. A moderate cardiovascular exam was carried out. Final diagnosis hypertension, well controlled on current medication, no change in treatment needed at this continue current medications. So again, callers, what ENM is reported? Your time begins now. I wish you well.
Okay, coders, that is time for the first scenario. Thank you, Ms. Stephanie, for reading that one for us. So, coders, before answering or before moving on explaining this scenario, I got a question for you all. Do you feel challenging for solving or picking the ENM level using MDM or our PDR chart? Do you find it as a challenging thing for you all? Okay, sometimes leveling is challenging. How about the others? Let's make this interactive session code. As this is the group study, this is unofficial group study. I mean, official group study. This is a place where you all can let us know how you are feeling. Chat. Okay, probably sometimes yes. Okay, we will be we will be focusing more on solving the scenarios using I mean the leveling using the PDR chart on the next on the coming week, so we will be focusing more on them. So no worries if you feel it as a challenging task. So for this scenario, let's start by highlighting the keywords: a 45-year-old male with a history of well controlled hypertension presents to the office for routine follow-up. Hypertension is well managed with current medication. A moderate cardiovascular exam was performed. Final diagnosis: hypertension, well controlled. The correct answer is going to be option B, 99213, and this is how we arrived into the correct answer. We will answer the questions which we are supposed to do before solving the ENM scenario. Whether there's a medically appropriate history or exam performed. Yes, there was a medically appropriate history and exam. Location of the visit: this is an office visit. And type of the visit, whether it's a new or established, it's not documented anywhere that's a new visit. And also mentioned that it's a routine follow-up, so we'll take it as an established visit. Total time: is there any time documented, coders? No, there is no time documented in the scenario. So yes, there's no time documented. So what we are going to do, we are going to skip the point number 4 and we are moving to the point number 5. We are going to inventory our MDM and then score, and then we are going to select the ENM from the table. So what are we having in the inventory? Diagnosis, signs and symptoms. We have a hypertension which is well controlled. Okay, in the procedure, what did the provider did or going to do? He had a history, medically appropriate history, a moderate exam performed, and he have told like you can continue the prescription medication, or it's a medication refill which has happened during this encounter. Now let's pick up our PDR chart and let's start leveling here. So where do you think, coders, it falls in the problem column? Okay, now let's interact. Where do you think it falls in problem column? Okay, low. Someone saying low. Specifically, specifically, which point would you take for an hypertension well controlled? Oops. Hypertension well controlled. Specifically, which particular point in a low category? Okay, there you go. One stable chronic illness. Exactly. So I would also take it as a low problem. Once one stable chronic illness. How about the data? Is there any review for of the data performed? No review of data was done here. So it will fall under straightforward data. And the risk, I see a prescription management. Doctor has given a refill. He has asked to continue the current medication. So that's a prescription management. So that will fall under a moderate risk. So leaving out the lowest level, selecting the next highest. Yes, I would take a low level ENM, and that would be 99213. So, how are you feeling? Let me know in the chat. Good so far, good so far. Okay. So, are you good with the explanation? Shall we move on to the next one? So, on week three, on the next week, we will be doing a lot of E&M. We'll be solving a lot of E&M scenarios based on leveling. So, don't worry, we are going to figure that one out. Yes, cool. Let's move on to the next scenario. And I think it's Miss Stephanie once again coming up to read the scenario for us.
Hello, coders. A 55-year-old female with a past history of type 2 diabetes presents to the office with new onset fatigue and increased thirst over the last few weeks. The patient reports increasing fatigue and thirst over the past few weeks. Despite main Despite maintaining her regular diet and exercise routine, she has also noticed an increase in urination frequency. She denies any chest pain, shortness of breath, or dizziness. A detailed exam was carried out. Labs were ordered and reviewed. Elevated HbA1c levels. Final assessment: poorly controlled type 2 diabetes with new suddenly onset to diabetes with new and concerning onset of diabetes. Fatigue, possible lab related to unconventional labs to rule no plan, order out other potential causes of fatigue. Dose 1,000 milligrams twice a day. Glipizide 5 milligrams once daily. Patient will advise to increase and follow up in 2 weeks. Answer A 99203, B 99204, 99213, 99213, and 99214. Your time begins now. You have 2 minutes.
That's time, and let me look into this chat. Okay, Goddess. So let me tell you, everyone got this one correct. So you all are doing pretty well with the ENM leveling. It's not a challenge for you all. Thank you, Miss Stephanie, for reading the second scenario for us. For the keywords for this scenario is going to be a 55-year-old female, history of type 2 diabetes, office visit, increased fatigue, increased thirst, fatigue, increased urination frequency. A detailed exam was performed, poorly controlled type 2 diabetes mellitus, and possible and fatigue that is possibly related to uncontrolled diabetes. Order additional labs to rule out the potential cause of fatigue, increase metformin dosage. And the correct answer is going to be option D, 99214. So let's ask the questions whether there's a history or exam performed, whether it's a medically appropriate history or exam performed. Yes. Location of the visit, this is an office visit. The type of the visit, is it a new or established? This is an established visit. There's no total time documented. We are going to do the inventory, our MDM, and then score the level. So we are having a poorly controlled diabetes mellitus and fatigue in our diagnosis inventory. And the procedure, there was a medically appropriate history exam performed. The doctor has ordered and reviewed HbA1c, which is to check the patient's diabetes mellitus, and there are plans for additional labs, and a prescription management also has been performed to increase the dosage of the metformin. So let's see, where does it fall in the problem column. Now this falls under moderate, and I would take it as a yes. I would take it under one or more chronic illness with exacerbation, progression, or side effects of the treatment. Do you agree, coders? Do you agree with me? Yes, everyone agrees. Yes, yes, yes. And how about the data? How about the data? What do I take in the data? Okay, I see. Okay, I see the answers coming now. I see only two answers. Come on, coders. Where do I take it in the data? Don't worry, even if it is wrong, don't worry. We are all learning here. Okay, now I see a lot of results. So I can see, yes, labs were ordered and reviewed, and HbA1c was ordered and reviewed. And in the plan, there were plans to order additional labs as well, but they haven't specified which lab is going to is ordered. So I will take it under low data, and in the risk, there is a prescription management once again in the scenario. There was an increase in dosage of metformin, so that would be a moderate risk. Once again, throwing out the lowest level. Yes, I can see everyone's responses in the chat. So I would throw the lowest level and select the next highest one, and that is going to be a moderate ENM level, and that would be 99214. Okay, so are you all good with the explanation, coders? You all must be good because you all have selected the same answer as I've selected. Yes, so the correct answer is going to be option D, 99214. So we will leave the practice scenarios on office visit for now, and we'll join back on next week. So let's move on and let's look into some other guidelines. Let's look into the chapter for neonatal intensive care, that is known as NIC, and neonatal intensive care unit would be known as an NICU. And the patients who are not critically ill but continue to require an intensive cardiac and respiratory monitoring, continuous and or frequent vital sign monitoring, heat maintenance, eternal and parenteral internal and parenteral nutrition adjustment, laboratory and oxygen monitoring, and a constant observation by healthcare team under direct supervision of physician or other qualified healthcare professional. They fall under intensive care category. So it's just below critical care. Yes, it's just below critical care. And we have few guidelines here for the neonatal intensive care services. The CPT code 99477 is coded for initial hospital care for neonate 28 days of age or younger who requires intensive observation, frequent intervention, and other intensive services. And we also have a code series from 99478 to 99480. The 99478 codes for report subsequent intensive care per day for evaluation and management of recovering very low birth weight infant, present body weight less than 1500 grams, and 99479 is a code which is used for subsequent intensive care per day for the evaluation and management of low birth weight infant, present body weight 1500 to 2500 grams, and the CPT code 99480 is used to report the subsequent intensive care per day for the evaluation and management of infant, present body weight 2501 to 5000 gram. These codes include the same procedure that are outlined in the neonatal and pediatric critical care service section, and these services should not be separately reported. So I believe you all remember those services which are reported in the neonatal and pediatric critical care. So same guideline applies here. Those codes won't be reported separately. And we got few more guidelines here. When neonate or infant improves after the initial day and no longer requires intensive care services and is transferred to a lower level of care, the transferring individual does not report a per day intensive care service, subsequent hospital inpatient or observation care, or subsequent normal newborn care is reported as appropriate based upon the condition of the neonate or infant. If the transfer to a lower level care occurs on the same day as initial intensive care service were provided by the transferring individual, 99477 may be reported. When the neonate or infant is transferred after initial day within the same facility to the care of another individual in different group, both individuals report subsequent hospital inpatient or observation care services. The receiving individual reports subsequent hospital inpatient or observation care or subsequent normal newborn care. So those were a few guidelines from neonatal intensive care, and let's move on and let's do a scenario under this chapter. So I think it's Miss Karen coming up next to read the scenario for us.
Good evening, everyone. Okay, let's see where the sentence at. What CPT code should be used by Dr. Adams' initial inpatient neonatal intensive case service for Noah? A 99468, B 99477, C 99478, and D 99479. A, a prenatal A premature baby, Noah, is born at 26 weeks of gestation and admitted to the NICU due to respiratory distress and low birth rate. Dr. Adams, a neonatal special board provider, daily management and provided daily management and monitoring of Noah, including vent vent support, total per prudential nutrition, and other necessary intervention. What CPT code should be used by Dr. Adams' initial inpatient neonatal intensive care service for Noah? You have 2 minutes.
So that is time and coders. Have everyone place the answers in the chat. Have you logged your answers? Okay, I will give you 5 more seconds to put your answers in the chat. Give your best shot. Okay, so thank you, Miss Karen, for reading the third scenario for us. And let me highlight the keywords for this. A premature baby, Noha, admitted to the neonatal intensive care unit. Low birth weight, ventilator support, total parenteral nutrition. The correct answer is going to be option B. And here is how. Whom are we coding here for? We are coding for the neonatology intensive care services for NOHA, for the Dr. Adam, who has performed the neonatal intensive care service. And option A, I see many of you have overlooked the option A here. 99468 is coding for initial inpatient neonatal critical care per day for the evaluation and management of critically ill neonate 28 days or of age or younger. So this particular code is, it might be a little bit confusing, or you might have overlooked this one. So this is for an inpatient neonatal critical care. So if you remember what I said during while reviewing the guideline, it's different from critical care. This is coding the service which we are looking here is here is for neonatal intensive care. So this is a little bit on the severity level. It's just below the critical care. So we are not coding for critical care services here. We are coding for intensive care service. So option A is incorrect, and option C and D is coding for 99478 and 99479. Both are coding for subsequent intensive care per day for evaluation and management. So again, this is not a subsequent intensive care which we are looking for. We are looking for an initial intensive care services. Option C and D is incorrect as well, and the correct answer is going to be option B, which is 99477, initial hospital care per day for the evaluation and management of the neonate 28 days of age or younger who require intensive observation, frequent intervention, and other intensive care services. So correct answer is option B. And coders, how are you feeling on that one? Okay, so good. So let's move on to next scenario. Let's see what we're having next. Okay, we are not going to review, we are not having a scenario coming up next. Next is another guideline. Yes, this is for pediatric critical care patient transport. And yes, the CPT code 99466 is used to report the physical attendance and direct face-to-face care by physician during the interfacility transport of a critically ill or critically injured pediatric patient 24 month of age or younger. The CPT code 99485 and 99486 are used to report the control physician's non face to face supervision of interfacility transport of critically ill or critically injured pediatric patient 24 months of age or younger, and pediatric patient transport services involving less than 30 minutes of face to face physician care should not be reported should not be reported using the codes 99466 and 99467. So that's an important guideline. The pediatric patient transport services involving less than 30 minutes of face-to-face physician care should not be reported using 99466 and 99467. So that's all about the pediatric critical care patient transport guidelines, and let's do a scenario on them. And once again, it would be Miss Karen who's coming to read the scenario for us.
What CPT codes should be used for Dr. Miller's pediatric critical care patient transport system service? A. 99291, 99466, C. 99463, and D. 99485. A 1-year-old patient, Lily, is diagnosed with severe pneumonia and requires specialized care at the pediatric hospital. Dr. Miller, a pediatric critical care specialist, accompanied Lily during the transport via ambulance from for the local hospital to the pediatric hospital, from the local hospital to the pediatric hospital. Dr. Miller provided continuous care and monitoring during the 45 minutes transport. What CPT code should be used for Dr. Miller's pediatric critical care patient transport service? You have 2 minutes.
And that's 2 minutes. And thank you, Miss Karen, for once again coming up and reading scenario for us. And let me look into the chat and let me see how you all are doing. Okay, so there is a little bit mixed response in the chat. So let me explain this one for you all. The keywords: 1-year-old patient, severe pneumonia, specialized care, critical care specialist, transport via ambulance. And what is the CPT code to be used for Dr. Miller's pediatric critical care patient transport service? Correct answer is going to be option B. And let's see why. So these are the code options that are available for us. And we are coding for a pediatric critical care patient transport services. So option D, it's not option D, option A, 99291 is coding for a critical care evaluation and management service. So we are not coding for a critical care evaluation and management, we are coding for critical care, pediatric critical care patient transport services. So both are different. So option A is incorrect. Let's see option C, that is coding for an inpatient hospital or birthing center per day. So we are not coding for, once again, for an inpatient hospital or birthing center care. So option C is also incorrect. And comes next option D, which is coding for a supervision by a control physician of interfacility transport care of the critically ill or critically injured pediatric patient 24 months of age or younger. So this was this I see most of them got it wrong between option D and option B. So option B, D is coding for a supervision of by a control physician. We didn't had a supervision of a control physician in our scenario. We were only coding for a Dr. Miller's services. So there was no physician who controlled this pediatric transport services in our scenario. And option D is incorrect, and the correct answer for this scenario would be option B, which is 99466, critical care face-to-face services during interfacility transport of a critically ill or critically injured pediatric patient 24 months of age or younger, first 30 to 74 minutes. So we got 45 minutes of transport service here. So that would be the correct answer. And how are you feeling, coders, on scenario 4? So once again, I would just review the guideline on this chapter for you all. 99466 and 99467 CPT codes. The provider accompanies and care for a critically ill or injured child in person who is 2 years of age or younger during the transportation between the facilities. And the CPT code 99485 and 99486 is used when the provider supervises the transport of a critically ill or injured child, 2 years of age or younger, between the facilities up to 30 minutes. And he communicates with the transport team before the transport, during the transport, and upon arrival at the receiving facility, and he interprets the patient data relayed by the transport team. So those are the two different code sets for pediatric critical care transport services. Hope the difference is clear for you all. One is for a supervision or by a physician, and the other one, the physician will be directly involved in transport of the patient. So are we good, coders? Shall we move to the next scenario? For the next chapter, yes, ready. Next, we are going to review the care management services. And what are care management services? So care management services are management and support services provided by the clinical staff under the direction of a physician or qualified healthcare professional, or may be provided by personally by a physician or qualified healthcare professional to the patient residing at home or in domiciliary, rest home, or assisted living facilities. So that's what a care management services are. So there are three categories of care management services provided. One is a chronic care management service. The CPT codes 9943799, 43999, 49099, 491 are used for chronic care management of patients who have two or more chronic conditions that are expected to last 12 months of age or until death. And we have a code series for a complex chronic care management 99487, 99489. Complex care management services addresses all of patients medical condition. And the third set would be for principal care management. The CPT codes are 99424, 99425, 99426, and 99427 for principal care management services, which address only a single condition. So these are the main difference between all the three categories of care management codes. These codes are further subdivided into those services that are personally performed by the physician or qualified healthcare professional, or those services that are performed by clinical staff overseen by a physician or other qualified healthcare professional. So these codes categories are further classified on the basis if the service is personally performed by a physician or qualified healthcare professional, or those which has been supervised or overseen by a physician or qualified healthcare professional, and it is done by clinical staff. So that's how these codes are classified. The code selection for these services is based on time in calendar month, and these are the major differences between all the three categories. Chronic care management is for the management of patients who have two or more chronic condition expected to last 12 months or until death. And complex chronic care management includes chronic care management criteria and establishing or revision of more comprehensive plan, typically receive three or more prescriptions and may receiving other therapeutic services. Moderate or high MDM services are 60 minutes, reported once monthly. And we have a principal care management services which focus on the medical or psychological need manifested by single complex chronic conditions expected to last at least 3 months of an 3 months, and include establishing and implementing, revising, or monitoring care plan specific to that single disease. So Chorus, if you want to take a screenshot, go ahead and take a screenshot, or they are also available in the CPT book. I have just made a table so that it can be easily presented to you in an understandable way. So let's move on. And these are the table for reporting chronic care management services. So as I said, these codes can also be divided based on whether the service is provided by a clinical staff directed by a PH or QHP, which is qualified healthcare professional and physician, or on the basis whether these services are directly provided by a physician or other qualified healthcare professional. So these are two categories, once again subdivisions under chronic care management services. So I have made in a tabular form once again so that you can easily understand. These tables are also available in your CPT manual. If you want to take a screenshot, please go ahead and take a screenshot of this particular slide coders. Okay, now let me move on to the next table for reporting complex. These are the table for reporting complex chronic care management services. If you want to take a screenshot, please go ahead. And finally, we have tables for reporting principal care management services. They are also once again classified into two subdivisions. One for the services provided by clinical staff directed by a PH or other qualified healthcare professional, or on the basis of the services provided by directly by physician or qualified healthcare professional. So don't worry, these tables are also available in CPT manual. So let me move on and let's do a scenario on this care management services coders. So this is scenario number, I think it's scenario number 5, and Miss Sandra will be coming up next to read and help us in reading the scenario for scenario number 5.
Hello, coders. I will begin reading the answers. A, 99487, B, 99489, C, 99490, and D, 99491. A 65-year-old patient, Mr. Smith, has multiple chronic conditions, including type 2 diabetes, hypertension, and chronic kidney disease. His primary care physician, Dr. White, provides care management services for Mr. Smith to ensure proper coordination and management of his medical care. Over the past month, Dr. White has spent a total of 50 minutes on non-face-to-face care management services, including reviewing Mr. Smith's medical records, consulting with other healthcare providers, and adjusting his medications. What CPT code should be used for Dr. White's care management services provided to Mr. Smith? Coders, you have 2 minutes.
Okay, coders, that is time. Thank you, Miss Sandra, for reading scenario number 5 for us. And from what I see in the chat, this is going to be maybe an aha moment. So have everyone entered their answers? I'll give 5 more seconds. Give your best shot, coders. Don't worry whether it's a correct answer or wrong. Only we instructional team is viewing your answer, so give your best shot. Okay, now let's start solving this scenario. What are we having? Let's highlight the keywords. We're having a 65-year-old patient, type 2 diabetes, mellitus, hypertension, chronic kidney disease. Dr. White's provide a care management services. Dr. White spent a total of 15 minutes of non-face-to-face care management services, and we are coding for Dr. White's care management service. So coders option A, AMCI. Okay, option B, 99489 is incorrect. I see a lot of the students placing option B as their answer. So why do you think option B is incorrect? Let me know, coders. Those who have selected the other answer, let me know why you think option B is incorrect. Okay. Okay. I can see your responses in the chat. Okay, I see 2 response. Mm, okay, there you go. Yes. I could have eliminated this option B quickly because that's an add-on code, isn't it? Can we code an add-on code without the primary code? They are not standalone codes. Add-on codes are not standalone codes. So sorry. So we can easily eliminate. Yes, I see aha moment in the chat. So we can easily eliminate option B because they are not standalone codes. They are they are add-on codes. Option B is incorrect straight away. Let's see what next one option is. Option C is coding for a chronic care management service with the following requirements. First 20 minutes of a clinical staff time directed by a physician or other qualified healthcare. So coders, how about option C? Why do you think option C is incorrect? Okay. Okay, so I see most of you are saying it's option B. C is incorrect because of wrong time. How about this particular thing which I have highlighted, chorus? So if you remember, I was repeatedly telling during the slides where I reviewed the guideline, these codes are classified. Most of these codes are classified into subclassified into 2 categories based on whether the clinical staff is overseen by a physician or qualified healthcare professional, or these if whether these services are directly provided by a physician or a qualified healthcare professional. So in our scenario, there was no clinical staff involvement. The service was directly provided by the physician. And option C, 99490, is coding for a clinical staff involvement which is directed by a physician or qualified healthcare professional. Have you got that one, coders? Is that clear? So option C is incorrect, and option A as well, because that is also coding for a complex chronic care management services. First 60 minutes of clinical staff time, which is directed by a physician or other qualified healthcare professional per calendar month. So once again, there is no clinical staff involvement in our scenario. And the correct answer would be option D, 99491, which is coding for a chronic, yes, chronic care management services with the following items, following required elements. First, 30 minutes, which is provided personally by physician or other qualified healthcare professional per month. And if you look into the table, yes, if you look into the table as well, for the first 30 to 59 minutes, you can only code one CPT. That would be 99491. Only if it reaches next 30 minutes, that is 60 to 89 minutes, we would code an add-on code, which is 99491 and 9949437. So the table is a lifesaver here. So is the explanation good, coders? Have you all got why I have selected option D as correct answer? Do you need further explanation on this scenario? Please let me know in the chat so that I can quickly go through them again. Okay, so everyone is feeling good. Yes, so remember these chronic care, these care services are classified into two categories. Just look for whether they have been directly given by a physician or qualified healthcare professional, or whether they has been given by a clinical staff who is directed by a physician or other qualified healthcare professional. So these are only a few things which you have to look, and take the help of the table if you need to, because they will direct you to the correct answer. Yes. So these are only for first 30 minutes. And for billing a second an add-on code, you have to reach next 30 minutes as well. So I think that was a good scenario. That was a little bit challenging for you all. And let's move on to the next one, coders. Once again, Miss Sandra will be coming to assist us in reading the scenario. Miss Sandra, please, and thank you.
Okay, let's start with the answers. A 99358, B 99484, C 99487, D 99483. A 58-year-old patient, Mrs. Martinez, has been diagnosed with early-stage Alzheimer's disease. Her neurologist, Dr. Nelson, develops a comprehensive care plan to manage her condition and slow down the progression of cognitive decline. Over the past month, Dr. Nelson has spent a total of 45 minutes on care planning, including reviewing Mrs. Martinez's medical records, coordinating with other healthcare providers, and adjusting her medications. What CPT code should be used for Dr. Nelson's care planning services provided to Mrs. Martinez?
That's more than 2.5 minutes. So, are you all ready with your answers, coders? Place them in the chat. Once again, don't worry if it is wrong. It's only the instruction team who are looking to your answers, and we are here to learn. Thank you, Miss Sandra, for reading scenario number 6 for us. So, okay, coders, have you placed your answers in the chat? I see only few answers so far. Don't worry, coders. Let us know what you think. Okay, so this one is going to be an interesting scenario. And the correct answer is going to be okay. We'll reveal the answer later. So let's highlight the keywords. I've given you some more time to place your answers in the chat. So, 58-year-old patient, early stage Alzheimer disease, neurologist Dr. Nelson, comprehensive care plan, past month, a total of 45 minutes of care planning, and that's all we have. And these are our code options. Let's look what 99487 is coding for. This is for a complex chronic care management with the following required element: first 60 minutes. And this one requires a multiple, that means two or more chronic conditions expected to last 12 months or until death of the patient. So how many chronic condition is addressed in this scenario, Goddess? Just one. Just one. Alzheimer is the only one which has been managed here. So option, yes, option C is incorrect. Now let's look into what's in option B is going for 99484, care management services for behavioral health conditions, at least 20 minutes of clinical staff time directed by the physician or other qualified healthcare professional per calendar month with the following required elements. So this is for just for a care management services. And what we had here, we had a complex care management services perform, and it's just not a care management services. So options, I think option B is also incorrect. And let me look into, yes, let me look into the next one. Yes, the option D. So most of you were telling correct answer is option D, which is for assessment and or care planning for a patient with cognitive impairment requiring independent historian in the office or other outpatient home or domiciliary rest home with all the following required elements. Yes, there was a decline in cognitive. Yes, it was mentioned. There was a slow down the progression of cognitive decline. But if you look carefully into the code language chorus, it requires all the following required elements. It requires a cognition focused evaluation, including pertinent history and examination, a medical decision making of moderate or high complexity, functional assessment, use of standardized instruments of staging of dementia, medication reconciliation. Was this all mentioned here? Evaluation of neuropsychiatric and behavioral symptoms, because it's clearly said in the code language that all the following requirements are needed in order to code 99483. And if you look into the guideline under cognitive assessment and care planning, you can see to not report cognitive assessment and care plan services if any of the required elements are not performed or deemed unnecessary for the patient's condition. For these services, see appropriate evaluation and management codes. So this guideline also states that if all these elements are not mentioned, we cannot code for cognitive assessment and care plan services. We have to go and check our code in evaluation and management code series. So we have a total of 45 minutes of care planning here, and that has been done over a past month. So we will go to for a long service section. And which code do we select here? Yes, we would select the code series from the code series 99358 or 99359 may be reported for prolonged services in relation to the evaluation management on a date other than face-to-face service, whether or not time was used to select the level of the face-to-face service. And how many minutes do we have here? We have a 45 minutes of care planning given, and that would be 99358. And that's not happen in a single encounter. So how was that scenario, Chorus? Was that an aha moment? Does the explanation help? I saw everyone asking you. I need an explanation for this scenario. So did the explanation help, Coder? Is it good? Shall we move on to the next scenario? Yes, read the guideline. Exactly. Read the guideline. Chun your CPT manual. That is key because it's normal to forget these guidelines because we have got a lot of guidelines to look up to. So if you have got your CPT book, Chun, that would be very helpful during the exam. So that's why we give more importance to Chun in part 3, because it's very time consuming. As I say in Tuesday study sessions, it might be time consuming, but it's each and every time you spend or each and every effort you put towards running your manual, it's worth. So once you come out of the exam hall, you will say, yes, Chan saved me. So let's move on to the next scenario. Shall we move on to the next scenario, coders? Are you ready for next challenge? Yes, so case number 7. So this time it's Miss Dania who's coming to read the scenario for us. Thank you, Miss Sandra, for reading the last scenario for us. Now it's going to be Miss Dania. Thank you, and please, Miss Dania.
Thank you, Mr. Sandeep. Uh, what CPT code should be used for Dr. Thompson's complex chronic care management service provided to Mrs. Johnson? A 99487, B 99489, C 99490, D 99491. A 75-year-old patient, Mrs. Johnson, has multiple complex chronic conditions, including congestive heart failure, chronic obstructive pulmonary disease, COPD, and type 2 diabetes with peripheral neuropathy. Her primary care physician, Dr. Thompson, provides complex chronic care management service to ensure appropriate coordination and management of her medical care. Over the past month, Mr. Thompson has spent total 75 minutes on non face-to-face complex chronic care management services, including reviewing Mrs. Johnson's medical records, consulting with her healthcare providers, and adjusting her medication. What's you have 2 minutes to solve this question.
So that is time, coders, and come on, place your answers in the chat. You got this one. Thank you, Ms. Zenia, for reading the scenario number 7 for us. Let's see what we are having. We are having a 75-year-old patient, multiple complex chronic condition, primary care physician, complex chronic care management services. A total of 75 minutes of complex care management services was provided. The correct answer is going to be option A. And let's see what option C is coding for, 99490, which is chronic care management services with the following required elements. So this one is for a complex chronic care management. Even option D, 99491, is also coding for a chronic care management services. So what did we had in our scenario code? We had a complex chronic management, chronic care management services provider. Yes, you can see the documentation. A total of 75 minutes of non-face-to-face complex chronic care management services were provided. So that means option C and D is incorrect. That leaves us with option A and B, and option B is incorrect because that's a standalone code. You cannot code them separately. So option A is the correct answer. Still, we can take the help of our table and place 75 minutes in the table. Where does it fall? It will fall in 99487 column. Okay, option A is only for 60 minutes and doctor did 75 minutes. So I think this particular table solved that question. For 60 to 89 minutes, only code 99487 units. Only if you reach that 90 minutes mark, you can code for the add-on code. Yes, that's why I say tables better. If you see a time-based services, go and confirm in the table as well, because there might be any hidden guidelines. So the table will guide you properly to the correct answer. So option B is incorrect in the scenario. The correct answer is option A, 99487. So coders, are you feeling good about the explanation? Shall we move on to the next? We got few more chapters to cover here. Yes, let's do it. That is the spirit. Okay, let's move on to the next chapter under evaluation and management, which is for a psychiatric collaborative care management services. So you can see these are psychiatric collaborative care services are provided under the direction of a treating physician or other qualified healthcare professional during a calendar month. The provided under yes during a calendar month, and these include the services of treating physician or qualified healthcare professional, behavioral healthcare manager, psychiatric consultant, and who has contracted directly with the treating physician or other qualified healthcare professional to provide consultation. So there are several parties involved in psychiatric collaborative care management services, as you can see, and the CPT has also given the definition for all these parties involved. They have defined what an episode of care is. They have defined who is a healthcare professional, who is a behavioral healthcare manager, and who is a psychiatric consultant. So coders, if you get time, please go and read those definitions. So a treating a physician or qualified healthcare professional will direct the behavioral healthcare manager, and a behavioral healthcare manager will collaborate with psychiatric consultant and maintain a collaboration between the physician and qualified healthcare professional, and a psychiatric consultant will advise and make recommendation, provides medical management. So if you get time, please go ahead and read those definitions and what are their roles. So these are the code for psychiatric collaborative care management services. You have an initial psychiatric collaborative care management code, subsequent psychiatric collaborative management code, and there is an add-on code for both initial and subsequent psychiatric psychiatric collaborative care management. Yes, so and we also have our favorite table. Yes. You can use the help of the table to get the correct answer. So next we are going to have another challenge, scenario number 8. So once again, Miss Dania is going to read the scenario for us. Miss Dania, please, and
Hello,
thank you.
hello, coders. What CPT code should be used for Dr. Lee's psychiatric collaborative care management service provided to Mr. Brown? A 99492, B 99493, C 99494, D 99495. A 42-year-old patient, Mr. Brown, is experiencing symptoms of major depressive disorder and generalized anxiety disorder. His primary care physician, Dr. Lee, coordinates with the psychiatric consultant, Dr. Martin, and behavioral healthcare manager, Ms. Jackson, to provide collaborative care management services. Over the past month, Dr. Lee has spent total 70 minutes on non-face-to-face psychiatric collaborative care management services, including reviewing Mr. Brown's medical records, adjusting his medications, and discussing his progress with Dr. Martin and Ms. Jackson. You have 2 minutes to.
That is 2 minutes quota, so I will quickly move on because I've got some more slides to cover here. So someone was asking for me to go back to the slide to take a screenshot of the table here. So don't worry, these tables are also available in your CBT manual. So here's a table for psychiatric collaborative care management service. Okay, so I will move on. This is the scenario which we were discussing. We have a 42-year-old patient, depressive disorder, generalized anxiety disorder. Primary care physician coordinates with psychiatric consultant, behavioral healthcare manager, collaborative management services, and a total of 70 minutes was spent for the collaborative care management services. And the correct answer is going to be option A. These are available code options for us. We are coding for Dr. Lee's psychiatric collaborative care management services. And option D is coding for a transitional care management service. So both are totally different cases. So option D is incorrect. This is for transitional care service. And let's see what option C is for. This is an add-on code. Once again, we won't be coding them alone. It's for an initial or subsequent psychiatric collaborative care management add-on code. And option B, which is for 99493, that's for a subsequent collaborative psychiatric collaborative care management first 60 minutes in a subsequent month of behavioral healthcare manager activity. So it was not a subsequent month where the collaborative care management was given. It was not mentioned like that. So option A is going to be the correct answer, which is 99492. That is for initial psychiatric collaborative management. Sorry, for the first 70 minutes in the first calendar month of a behavioral healthcare manager activities in consulting with psychiatric consultant directed by the treating physician or qualified healthcare professional in the following with the following elements. So that is going to be the correct answer for us. So let's move on to the next scenario. So I'm just quickly moving on, coders. So we have to cover a few more scenario here. Yes. Next one is going to be transitional care management. And what's a transitional care management? We have few guidelines here for them: 99495 and 99496, which is used to report transitional care management services, TCM. These cases have moderate or high level of medical decision making during the transition in care from an inpatient hospital setting, partial hospital, or observation status in hospital or skilled nursing facility, a nursing facility to the patient's community setting. TCM or transitional care management comprised of one face-to-face visit within the specified time frame in combination with a non face-to-face services that may be reported by physician or qualified healthcare professional or licensed clinical staff under her direction. And these are the transitional care management service codes. And yes, medical decision making and the date of the first face-to-face visit are used to select and report appropriate TCM codes. For 99495, the face-to-face visit must be occur within 14 days, 14 calendar days of the date of discharge, and there must be at least a moderate level medical decision making. So coders, these are two important points you have to look under transitional care management: medical decision making and the date of first face-to-face visit. So with that given, let's do a scenario on transitional care. And this time it is Miss Sandra who's coming back to read the scenario for us.
Okay, let's look at our answers. A, 99495, B, 99496, C, 99497, and D, 99498. A 68-year-old patient, Mr. Smith, is discharged from the hospital following a 10-day stay due to a myocardial infarction. His primary care physician, Dr. Patel, provides transitional care management services to ensure a smooth transition from the hospital to home and to coordinate Mr. Davis's follow-up care. Within 2 days of discharge, Dr. Patel communicates with Mr. Davis via phone call and schedules a face-to-face visit within 7 days. Dr. Patel reviews Mr. Davis's medical records, adjusts his medications, and coordinates with other healthcare providers involved in his care, and moderate MDM performed. What CPT code should be used for Dr. Patel's transitional care management services provided to Dr. Patel?
Thank you, Miss Sandra, for reading the scenario 9 for us, and we are seeing some great response in the chat. So we have a 68-year-old patient discharged from the hospital following a 10-day stay. Primary care physician Dr. Patel provides transitional care management within 2 days of discharge. Dr. Patel communicates with Mr. Davis via phone call and schedule a face-to-face visit within 7 days. Adjust his medication, moderate MDM perform. So what are we coding for? We are coding for a transitional care management services, and option C is coding for 99497, which is an advanced care planning. This is not an advanced care planning. This is transitional care management performed here. So option C and D both are incorrect straight away. Let's look what option B is coding for. Now option A and B is coding for a transitional care management service. So coders, let me know why option B is incorrect. Why is option B incorrect? Those who have selected option A, why is option B incorrect? Yes, yes, you got this one correct. And that's what I explained during the review of the guideline. These the selection or the factor which drives this code selection is one is the MDM. Second one is when they have the visit after the discharge. So in option B, 99496, yes, there is a high level MDM, but that was not in our scenario. We had a moderate MDM in our scenario, and the face-to-face visit happened within 7 days. Well, in the scenario, it was mentioned that the face-to-face visit happened within 2 days of discharge. That happened within yes, that happened within 7 days of discharge. It was mentioned in the scenario. Even though that satisfied that factor, that requirement is satisfied, but it's not satisfying for the MDM because 99496 is coding for a high level MDM. And option A 99495, it is satisfying both the criterias because face-to-face visit should have happened within 14 days of discharge in option A 99495, and at least a moderate level medical decision making should have been also made place. So option A is satisfying both the criteria. So Chorus, is that clear? What differentiate between option A and B? I hope that concept is clear for you all. Yes, okay. Now let's quickly move on to the next chapter. We are almost reaching towards end. And this is for advanced care planning. And these are the guidelines for advanced care planning. Okay, the code CPT code 99497999498 is used to report the face-to-face services between a physician or other qualified healthcare professional and a patient, family member, or surrogate in counseling and discussing advanced directive with or without completing relevant legal documents. An advance directive is a document appointing an agent or recording the wishes of the patient pertaining to his or her medical treatment at a future time should he or she lack the decisional capacity at that time. So that is what an advanced care planning is all about. And we have a scenario on advanced care planning, and Miss Denya would be coming for read this scenario, the scenario number 10.
Hello, coders. What CPT code should be used for Dr. Wilson's advanced care planning service provided to Miss Green? A 99497, B 99498, C 99499, D 99500. A 72-year-old patient, Mrs. Green, visits her primary care physician, Dr. Wilson, to discuss advanced care planning. Dr. Wilson spends 40 minutes with the Miss Greens, discussing her preferences for future medical care, including her goals, values, opinions for end of life care. He also discusses appointment of healthcare proxy and complete the necessary forms. You have 2 minutes to solve.
And I think, Miss Dania, they didn't needed 2 minutes to solve this one. They were right from the beginning. They were answering these questions. So we have 72-year-old patient visits her primary care physician to discuss advanced care planning, spends 40 minutes discussing future medical care, appointment of healthcare proxy. The correct answer is option A. We are coding for advanced care planning. Option D, I think, yes, option C is coding for unlisted evaluation and management service. We're having a specific code here, so no need to take those unlisted code. And option D is coding for 99500 home visit for prenatal monitoring. This is not a home visit for prenatal monitoring. We are coding for advanced care planning. So option D is also incorrect. Option B is coding for, now this is an add-on code. Once again, we won't be coding them separately. We have to code them along with the primary code. And option A is the correct answer, which is 99497. That is for advanced care planning for the first 30 minutes. So that is going to be our correct answer for the scenario. Yeah, so this is coding for the first 30 minutes, and 99498 should only be coded if additional 30 minutes is met. So we have only 40 minutes of time spent in this scenario. There's no additional 30 minutes. So are we good, coders? Shall I move on to the next? And the last topic of the day. Yes. And the next one and the last chapter under evaluation management, which we haven't covered, is standby service. The CPT code 99360 is used to report a physician or other qualified healthcare professional standby service that are requested by another individual and involve prolonged attendance without direct face-to-face patient contact. The care or service may not be provided to the other patients during this period. So that's all about guidelines for standby services, and we are going to do the final scenario for week 2, and I'm going to read the scenario for you all. So is the last option visible for you all? Yes, option D is visible. Oops. Okay, a 42-year-old patient. I'll read the answers first. What is the CPT code for standby service for anesthesiologist? Option A 9963. I think it's 99360. Sorry. Option B 99360 times 2. Option C 99360 times 3. Option D 99360 times 4. A 42-year-old patient is scheduled for a cardiac catheterization. The cardiologist requests that anesthesiologist be on standby in case the patient experiences complication during the procedure. Anesthesiologist arrives at the hospital 1 hour before the scheduled procedure and remains on standby for the duration of the procedure, which is 1 hour 25 minutes. What is the CPT code reported for the standby services by the anesthesiologist? Coders, you got 2 minutes to solve this one. Let's see how fast you're going to answer this. So option A is 99360. And your time starts now. And that is time. And you guys are doing a great job in the chat, coders. So we're having 42-year patient scheduled for cardiac catheterization requests that the cardiologist requests that anesthesiologist be on standby. Anesthesiologist arrives and remains on standby for a duration of 1 hour and 25 minutes, and the correct answer is going to be option B here. And these are time-based codes, so specifically we have to go and look for the time spent on standby, and that is going to be 1 hour and 25 minutes. That is how many minutes? That is 85 minutes if I'm not wrong. And we have only one code, 99360, which is standby service requiring prolonged attendance each 30 minutes. So coders, be careful about the mindful about the code language. This one is coding for each 30 minutes. And we are also having a guideline or instruction here: second and subsequent periods of standby beyond the first 30 minutes may be reported only if a full 30 minutes of standby was provided each unit service reported for each unit service reported. That means in order to report a quantity 2 or quantity 2 for the service 99360, each 30 minutes must be complete. That 30-minute cycle must be complete. So we are having 85 minutes here, right? So first 30 minutes, it would be 99360. And for the second 30 minutes, it would be 99360 one more time, the quantity total of 99360 quantity 2. And for the third 30 minutes, we can't code them because it's not completing 30 minutes, it's just 25 minutes. So it is short by 5 minutes. So we won't be coding them. So the correct answer is going to be 99360 times 2. So is the explanation good, coders? Is that helpful? Is that helpful? Yes. Yes, thank you. So I would end the session by what Miss Stephanie was quoting on behalf of BB King. The beautiful thing about learning is that nobody can take it away from you. So if you have learned something that's priceless, if you got it correct, that is also too good. So thank you for attending the week 2 ENM group study, and let us know, is this advanced ENM group study helping you all in solving the scenarios? Just let us know in the feedback. And a heads up for the next week. Next week, I'm going to raise the bar a little bit. That is going to be a really advanced ENM session, and we will be working, as I said, we will be working on MDM scenarios, leveling scenarios, and there will be no options for you guys. You have to select the correct ENM code by yourself from the CPT. There would be no option. So we are just raising a bar by little bit. It's a week 3, and I know from what I've been seeing from week 1, I know you guys got this. You guys are going to rock the next week as well. So till next week, thank you, and stay safe. Keep coding. Thank you, team. Thank you, my intern team, and thank you, coders, for joining us. Please leave us a feedback, and see you all next week. Goodbye and good night for you all, and it's a good morning for me. See you all on next Tuesday. Bye, coders. Good night.
Thanks for tuning in, and until next time, happy coding!